Uh-oh. Hi guys. Good evening. Good evening. Can you all hear me? Can you all see me? Right, right. I think now, yeah, I think it's back on. Yeah, so as I was saying, yeah, got it, beta. Got it. Okay. So, as I was saying, today's BLS series is going to be on breast cancer. We'll try to discuss the important components of it. Hi guys. Hi Dr. Gaming. Good evening. Good evening. As I was saying, because of the mic, I think it was on mute, you couldn't hear. Today's BLS is only going to be half an hour. The reason being, I have an emergency OT at 10:30. We are doing a thoracic trauma. They're quite intriguing. They're quite challenging as well. This patient is landed up with hemothorax in trauma, as we have discussed it. So what is an indication for thoracotomy, especially in a post-thoracic trauma? When you put an ICD, if there's a stat 1000 ml bleed in a penetrating injury and 1500 ml blood loss in a blunt trauma, right? That is the first indication. Second, if more than 200 ml of blood loss per hour for next 3 consecutive hours, or patient is hemodynamically unstable. So all these are the indications, right? So we have one of these patients who's been now prepped up. We are arranging for blood and all. So by the time it gets ready, by 10:30 we're going to explore. After this, yeah, I'll share the case details on my Telegram group as well as on the Instagram. To know what was the case today and how we did it and what we did it. That's another important thing to be assessed. Apart from that, I'll not be taking BLS tomorrow and day after tomorrow. For this week alone, we are trying to put off the BLS. The reason being, I'm working on something which is going to be quite important and big for all the NEET PG, INICET and FMG aspirants. It's going to be a huge surprise with a big bang. We're going to launch it next week. So I'm going to focus a bit of energy towards that side because it takes a lot of time, energy, brain, mind, soul, everything. So that's the reason that we are not going to do BLS for the next 2 days, right? We'll continue from the next week onwards. I regret that we'll not be able to do so. If energy and time permits, I'll try to come and do at least half an hour lecture. Otherwise, we'll try to take it up from next week as well. Now, today we start with breast cancer. So in the breast cancer, what are the important things that we should know? Number one, if you look at what is the most common cancer, we talk about the most common cancer for females worldwide. For females worldwide, currently the answer is going to be lung cancer. It is going to be lung cancer, right? No matter where you are in, whether you are in India, whether you are in South Asian countries, European countries, now it is the lung cancers. The same validates for male also, right? After lung cancers, if anything else, then I would say it is the breast cancer. Yes, breast cancer is a very, very, I'd say, yes, it's by prevalence, it's quite high there, right after the lung cancer. Now, if I change the question and ask you, what is the most common cancer, which is the most common cancer causing mortality? Causing mortality in females. Causing mortality in females, the answer still remains as lung cancer only, right? So if they ask you which is the most common cancer overall in the world, is going to be breast cancer, and one that causes mortality is also going to be your lung cancers. So today the discussion is not on lung cancers, it is on breast cancer. So let's talk about what are the risk factors that are going to be associated with the breast cancer, right? Now, when you talk about the risk factors, I am going to classify them into 2 categories. One is going to be a modifiable risk factor. One which classifies as modifiable risk factors. Another one is going to be a non-modifiable risk factors. So I'm going to segregate the risk factors into 2 categories. One is a modifiable risk factor. One is a modifiable risk factor. Another one is a non-modifiable risk factor. One is a modifiable risk factor, another one is a non-modifiable risk factors, right? Now, when you say modifiable and non-modifiable, we'll stick to one component, which is modifiable or non-modifiable, right? So we'll start with the non-modifiable one. Now, which is the, let's keep it this way. Which is the most important risk factor for breast cancer. ठीक है. HM, yes, आज का template is a little bit different. Templates का थोड़ा issue हो रहा है. I try to update with the team as well from the next series, I mean from the next episode as well. You'll see all the templates being spot on. ठीक है. We still continuing on the breast वाला ही. Breast cancer अभी खत्म नहीं हुआ है. It will take another week or so, and then after that we'll start the GIT. ठीक है. Now, in a non-modifiable risk factors, as I told you, which is the most important risk factor for breast cancer. Now, I give you a chance to tell me if you have to give me, I know you know a lot of risk factors, I do know. Give me one risk factor or the most important risk factor that is responsible for breast cancer. Remember, the most important risk factor for breast cancer, it is not the age, it is not the genetic component, it is not obesity, it is not hormonal therapy, it is not family history, nothing. The most important is being a female itself, right? So being a female itself is considered to be as the most important risk factor. 99% of the breast cancers are seen in females. Only 1% of the breast cancer accounts for male. So being a female itself is a risk factor for breast cancer. So sex, obviously, you can't change, you cannot modify female into males, right? There's different context to it. I mean, if you're going with your, let's say, gender transformation surgeries and all, but then you still can't change the XX and the XY chromosomes, right? So still, genetically, you're still a female, right? So being a female is a risk factor for breast cancer. And remember, it's a non-modifiable risk factor. The other non-modifiable risk factors is age, because age will only increase. It will never decrease. So as age increases, the risk for development of breast cancer also increases along with it. Okay? So the second risk factor is the age. The third risk factor is the family history. Again, you cannot change this, no? So family history of breast cancer. Now, what is more relevant for us is this family history of breast cancer is more relevant if it is seen in the first degree relative. If it is seen in the first degree relative. If it is seen in the first degree relative. Now, when I say first degree relative, it is the mother, sister, daughter, right? So these are the first degree relatives, which is going to be in the context of breast cancer, so positive family history. Now, this family history can also be taken with respect to genetic components. We have the genetic predisposition. Now, the genes which are responsible for the breast cancers, we all know two common genes. One is your BRCA1 gene mutation. Another one is your BRCA2 gene mutation. The other ones which you usually do not remember is P53, which is also called as a Lee-Forman syndrome. And another gene is going to be STK11, that is going to be Peutz-Jeghers syndrome, also associated with STK11 gene mutation. See? We'll talk about what is Peutz-Jeghers when we go into GIT. So now we have BRCA1 and BRCA2. Again, a lot of things has been asked around in BRCA1, BRCA2. So this is one of the most common famous question. Even in your Robbins pathology, they would have asked you multiple times, right? So when you compare BRCA1 and BRCA2, remember the chromosome on which is formed. So the chromosome on which you will see the BRCA1 is going to be chromosome number 17, BRCA2 will be seen on chromosome number 13, right? Now, both of them are associated with invasive carcinomas. Which variety? Remember, both of them are associated with invasive ductal cancers. They're usually associated with invasive ductal cancers, right? Now, when you talk about the BRCA1, when you talk status of the hormone receptor, the hormone receptor status for BRCA1 is usually negative, BRCA2 is usually positive. That is why when we say the BRCA1 associated breast cancers, when you talk about their differentiation, these are poorly differentiated. These are poorly differentiated, and this is well differentiated, right? Okay. Right. So these are the comparison between BRCA1 as well as BRCA2 components, right? Now, when you talk about chromosomes are important. When I say chromosome 17, chromosome 13, now which arm? Again, if they don't want to confuse you, always the long arm in these two. So chromosome number 17q as well as 13q, right? Now, BRCA1 and BRCA2 is also known to be associated with other cancers. Not only breast cancer, the BRCA mutation is associated with other malignancies also, right? So what are the other cancers to which it is associated with? It is associated with female breast cancer, as we just learned. It is associated with female breast cancer. It is associated with ovarian cancer. It is associated with the male breast cancer. It is associated with male breast cancer, pancreatic cancer, and the prostate cancer. Now, these are the other malignancies to which your BRCA component is usually associated with. Now, which is more likely to be associated? Remember, the breast and the ovarian cancer risk is more with BRCA1 when compared to BRCA2, right? From here onwards, the male breast cancer, the pancreatic cancer, and the prostate cancer is more likely to be associated with BRCA2 when compared to BRCA1, right? So this genetic component itself is associated with other malignancies, the female breast cancer, ovarian, male, pancreatic, prostate. But when you talk about incidence, it is when you talk about all the male component, no, male breast cancer, pancreatic, prostate is more with BRCA2. Female breast, ovarian is more with BRCA1 component. It is more with that of BRCA1 component. Just give me a second, guys. Hold on for a second. Right. So these are the risk factors which are associated with the genetic component, right? So we had the female, sex, age, family history, genetic component. Then you have the hormonal component. Now, in the hormonal component, we talk about early menarche. It is going to be the early menarche. Now, when you say early menarche, so early menarche indicates that early exposure to the estrogen. So the lifelong duration to which the estrogen exposure is there is quite elongated. So hence the patient has higher risk. See, the whole game of breast cancer is because of hyperestrogenemia. Whatever causes hyperestrogenemia or more exposure or greater concentration of estrogen can increase in result or risk for breast cancers. So how early is early? When we say age less than 12 years, again, this cannot be modified. Then you have late menopause. Okay, so you have late menopause. So when I say late menopause, it is age above 55 years. So early menarche, it is early menarche and late menopause. So early menarche is age less than 12 years. Late menopause is age above 55 years, right? Now, there's certain conditions which are associated with high risk per se, right? So in the what are the components when you talk about high risk breast lesions? So we have something called as the high risk breast lesions. If these are present, again, there will be a very, very important risk factor for development of breast cancer. Prashant, I'm in 10th, but I like your teaching style. But if you're in 10th and you're watching this lecture and if you're understanding it, I mean, like, I'm already so much amazed by Gen Zs, no? Like, they have it all, right? I mean, if you're able to understand this, kudos, boy. I mean, this is what we teach in MBBS 4th year. This is like in your final prof. This is channel surgery. If you're able to understand that, great. Now, when you talk about high-risk breast lesion, what are the high-risk breast lesions that we can think about it? Now, if you have a patient who has a breast lesion without any atypia, so proliferative disease, any proliferative disease, with or without atypia. Okay, that increases. Then you have complex fibroadenoma. Now, in a complex fibroadenoma, usually we have already discussed it. If the size of the fibroadenoma is more than 5 centimeters or it has some atypical component, then it is going to be your complex fibroadenoma, right? That's when we will start GI system, sir. GI system will start once we're done with the breast. I think another 1 week, we will announce it in a clear focus that when we are going to pull up with GIT. Okay? Now, this is going to be a proliferative disease if there is any complex fibroadenomas. If any papillomatosis is there, if there is any papillomatosis, then you have any ductal or lobular hyperplasias, any condition that is ductal or lobular hyperplasia, ductal or lobular hyperplasias. And if there is an LCIS, LCI stands for lobular carcinoma in situ, right? LCI stands for lobular carcinoma in situ. Now, the component is lobular carcinoma in situ, even though it sounds as carcinoma, it is not. Remember, LCIS is actually a pre-malignant condition. Yes, it has got a very higher prediction for development into the breast cancers. Remember the highest risk or the maximum risk for malignant transformation. The maximum risk for malignant transformation. The maximum risk for malignant transformation, it is going to be with LCIS. With a printed notes, I think it is going to be available by the mid of this month. Everything has been sorted. I think all the previous subscribers have got their printed notes as well. Those who haven't got it, the next batch is going to be launched, I think first or second week of the Feb. You can just check it there as well. Okay? So this is in terms of your non-modifiable risk factors. So we have all the non-modifiable risk factors. On one hand, no matter kitna haath pav maar lo, jo marzi kar lo, these are not going to change, right? So this is something that I say patient is blessed with. We can't change it. But what we can definitely change is the modifiable risk factors. So when we talk about the modifiable risk factors, the modifiable risk factor, number one is going to be obesity. Now, how does obesity increase the risk for breast cancer? In obesity, there is more fat. Fat peripherally converts into sex steroids. One of them is estrogen. So obese people have higher estrogen concentration. As I told you previously, hyperestrogenemia is a major risk factor for development of breast cancer. Then it is the parity. Now, if I say the patient is having nulliparity, that means never been pregnant, that means there is never in her age or in her life that the estrogen concentration gone down, because in pregnancy estrogen decreases, progesterone picks up, the concentration of estrogen drops. That is what we want. But this nulliparity is never going to be in that context. So obviously nulliparity increases the risk for breast cancer. Now, avoiding breastfeeding. Now, ideally we say that the breastfeeding should be done, right? In fact, if I give you a small statement, no, those patients who have a history of breastfeeding for more than 12 months, they have a relatively lower risk of developing breast cancers. Okay? Tanya, I don't know what you're trying to say. Okay, there's some irrelevant chat is there. So obesity, yes, you can modify it. Parity, you can encourage the patient to have children. I'll ask the patient to have breastfeeding. If you breastfeed for more than 12 months, obviously the risk decreases further. Another one is the age at first childbirth. Another one is the age at first childbirth. Now, this has been a point of debate as well as controversy. Now, let's say you have a friend, right? And that friend is worried that she might get breast cancer. And she says that I heard that if you have kids, and that too in an early age group, the risk of developing breast cancer reduces. So if she asks you what is the ideal age for her to have a kid, okay, best age for development of to have a kid, what should be your advice, right? There have been different literature suggesting you different components. So we say that if you talk about an early age for childbirth, right? So early age for childbirth is age less than 20 years. Obviously risk is less. Then if we say late age for childbirth, that is going to be age about 35 years. Age about 35 years. So here the risk for development of breast cancer reduces. Here the risk for development of breast cancer increases, right? So age at first childbirth is important. Less than 20 years, it is going to reduce the risk. More than 35, it increases the risk. But if you have to give me an ideal age where you have a relatively lower risk, right? So this should be under 30 years. See? So do not get confused. If they ask you what is protective in order to, substantiate your breast cancer risk factor, if a patient has a child in age less than 20, it is protective, right? Above 35, it increases the risk. Between that, it's same. Neither increase nor decreases. But ideally, when should you, age at first childbirth, if it matters, closer to the age of 20 is better. But we say age less than 30 is what is acceptable. Okay? So that is the age at the first childbirth. Now, another one is usage of hormonal therapy, that is HRT. Smoking is everywhere, so obviously it is going to increase, as well as alcohol. As well as alcohol consumption. Right, so usage of hormonal therapy, smoking, as well as alcohol consumption, right? All these. But breastfeeding prevents breast cancer, not bladder cancer, right? It is for breast cancer, not bladder. Now, how does it prevent is, as long as the patient continues to breastfeed, so obviously the cycle of your hypothalamus, that oxytocin, then prolactin, and then in milk injection, cycle continues. When this cycle continues, it suppresses your sex steroids, that is your estrogen secretion. So as long as the patient is breastfeeding, the concentration of estrogen in the body remains low, right? And if patient stops breastfeeding, it starts to pick it up. So ideally, as more and more period of breastfeeding is there, it reduces the concentration of estrogen in the body. The hyperestrogenemia is less, and because the hyperestrogenemia is less, the risk for development of breast cancer reduces. On the other hand, if the patient is not breastfeeding, let's say patient had a kid today and she's not feeding from tomorrow itself, she's like, I'll not feed, right? So that means what? Obviously, when she stops feeding, the milk production will decrease, and within a month's time, it will substantiate. In that context, her hyperestrogen, the estrogen starts reverting back by first month itself. So the concentration of estrogen starts to rise. So obviously she's exposed to hyperestrogenemia, which is not seen if a patient is breastfeeding. So hence, in that way, it reduces the risk for development of breast cancer. Right. So in the breast cancer status, you should know that, okay, along with alcohol, another one is going to be radiation exposure. That is ionizing radiation exposure. It is the ionizing radiation exposure, right? So all these are going to be associated with that are the risk factors for breast cancer. Okay? So whenever we talk about the risk factors for breast cancer, you should know which are modifiable risk factors, which are non-modifiable risk factors. Modifiable ones are the one which I have written here, where you can, alter by giving advice. Like for example, lifestyle, obesity, ask the patient to have kids, ask them to, breastfeed it, that is promote breastfeeding, suggest them to have a child at the early age, that is age less than 30, prevent usage of hormonal therapies, ask them to quit smoking, no alcohol, and then obviously whenever possible, no radiation exposure. These are something that I cannot change. Being a female, God couldn't change. What will I change? As age increases, the risk for breast cancer also increases, right? See, thelarchy occurs between 9 to 11. That means the breast will only start developing after 11 years of age. Before 11, there is no breast. When there is no breast, there is no breast cancer. But as the breast continues to grow, the changes will happen and the risk will continue to increase. So as age increases, the risk for development of breast cancer also increases. Family history, kukarma, jo hai apni family mein wo hai, you can't change that as well. Genetic component, again, it is a gift from your forefathers. Can't change it. They have given it. It is like mandir ka prasad. Ab diya hai to lena padega. You can't avoid it. Early menarche, remember what is early? It is age less than 12. Late menopause is age above 55. These are the high risk lesions. If it is present during any phase of the patient's presentation, you should advise them that yes, they should get an annual screening done. Otherwise, they can transform into malignancies. Yes, these lesions should also be removed also. Right? So these are the important risk factors associated with breast cancer. Okay? So today we are going to end the BLS here. Right? We'll resume back next with the clinical presentation and the management and staging for breast cancer. Right? Thank you so much for joining today. As I told you, we are going to have something really big coming up in the next week. It's going to be a blast. It's going to be game changer, especially if you are from preparing for NEET, PG, INICD or FMG exams. Stay tuned for another 1 week. From the surgery's point of view, you will see something really, really amazing getting up, right? So thank you so much for joining. I'll catch you up next week. Thank you guys. Bye.